Good morning, everyone. It's 11:30, so we better make a start. Welcome to this session of the Managing Corneal, Conjunctival, and Anterior Segment Trauma. On my left, needs no introduction, is Professor Mad Dog Charles McGee. And on my right, I'm sure known to you and internationally and locally, Dr. Geeta Aya, from Chennai. And I'm Alvin Young from Hong Kong. Very honored to be here and to chair the sessions with these esteemed faculty. So without further ado, our first speaker is from Zhongshan, China, but she couldn't be here because of visa problems, so there'll be a recorded video. Yeah, please. The other day she was supposed to speak and also no sound, same thing. Are you playing?
Do we have sound?
It's not even playing. I think should be a very relaxed session.
Mm-hmm.
There's plenty of time. So
Yeah.
you want to do the questions in between?
At the end, I think. What do you think? Do you want to do them all at the end? Or just make it feel better?
While we are waiting for the video to get sorted, we're going to leave the questions Q&A till last. So if all the speakers could stay till the last, please. Okay. Leave the Q&A till last. Yeah.
Efficiency. Consequently, conventional approaches like the Boston Capro type 1 are often contradicted. For these complex cases, the Markov Capro made in Russia offers a valuable alternative. Its design has proven robust for severe compromised eyes. From 2000 to 2004, the Markov Capro were utilized at the Chinese PLA General Hospital. Clinical trials from the China-made Mihe Capro began in 2015. The device subsequently received approval from the China's NMPA, formerly CFDA, in 2021. Together, we have over 20 years of clinical experience. The device consists of a titanium frame with a central rigid PMMA optical cylinder. Stage 1 involves creating a corneal pocket and then implanting the titanium frame. The second stage procedure is scheduled after 3 months. This will involve initiating paraplanar irrigation, followed by excision of the superior central corneal tissue and extraction of the lens. The optical cylinder will then be screwed on the frame. The surgery will conclude with the removal of the residue cortex, iris, and anterior vitreous using PPV. The second stage procedure is scheduled after 3 months. This will involve initiating Effective management of postoperative complication is critical to the long-term outcome of capro surgery, especially concerning corneal melting, leakage, and device extrusion, which may establish a direct fixture between the intraocular and external environments and increase the risk of endophthalmitis, one of the most threatening complications. To address this, our team has pioneered the use of autologous auricular cartilage reinforcement. Initially, this was employed as a secondary procedure. This video demonstrates our technique using autologous auricular cartilage reinforcement, ACR technique, to manage corneal melting. The two-piece cartilage can cover and stabilize the frame. Building upon the success of cartilage reinforcement, We integrated this step into the primary surgery. During stage 1, we placed the one-piece cartilage graft over the frame. This creates a sandwich-like structure, providing enhanced structural stability. Building upon this, I will demonstrate the surgical process through several cases study. This patient is a 51 years old female who has suffered from bilateral corneal glaucoma due to MMP. In stage 1, we create a lamellar corneal pocket in the center of the cornea and implant the titanium frame. Autologous auricular cartilage was sutured on the surface of the cornea. Three months later, in stage 2, vitreous perfusion were performed to establish optimal intraocular tension. Then, the underlying corneal tissue were removed and the optical cylinder were screwed on the frame. Markov caper represents a reliable and effective method for restoring vision. In our study with an average follow-up duration of 8 years, the retention rate is 84.6%. Also, the classic Markov procedure has desirable long-term outcomes. The surgical cycle is prolonged due to the 3-month interval. Therefore, our team has innovatively proposed a one-stage surgery approach using the Mihe caper. Also, this is a 70-year-old man with extensively keratinized ocular surface caused by MMP. Considering his age and overall health, the one-stage procedure is highly suitable. The video highlights the key steps. We observe severe surface keratinization, necessitating initial debridement. Viscoelastic is used to maintain a clear view. Phaco emulsification is performed. A lamellar pocket is screwed for the frame. Central corneal tissue is removed using trifines, and the optical cylinder is securely screwed on the frame. Finally, the auricular cartilage graft is positioned and secured over the frame periphery, completing the entire implantation in one sitting. The patient's postoperative BCVA improved to 20/25. Our preliminary experience with one-stage techniques is encouraging. From May 2023 to November 2024, we performed this procedure on 70 eyes in 17 patients. With an average follow-up of 9.57 months, we currently have a 100% capital retention rate in this cohort. Visual acuity outcome in the one-stage group are also promising. 74.3% achieved 200 or better, and 62.9% achieved 2100 or better. Post-operative complications are similar to those seen in two-stage procedure.
Is the video playing? Excuse me.
The most significant advantage of our one-stage technique is the elimination of the 3 months surgical interval, drastically shortening the treatment timeline. From a surgical perspective, performing intraocular maneuver like a complex cataract extraction or even retinal procedure is facilitated by the absence of pre-existing tissue flap or cartilage covering the capsular frame. For the patients, this translates to reduced anesthetic risk, lower overall cost, and a significant shorter waiting period for visual rehabilitation. In conclusion, keratoprosthesis implantation remains the last resort, but a crucial sight-restoring option for end-stage corneal blindness. The surgical technique are continuously evolving. Our modification incorporating primary AACR and developing a single-stage implantation protocol represent efforts to enhance stability, improve efficiency, and reduce patient's burden. Nonetheless, the long-term success of any capsular surgery fundamentally rely on meticulous surgical technique and the vigilant prevention and management of post-operative complications. Thanks for your kind attention.
Good morning. My apologies for coming late. I was held up in another session. So it gives me great pleasure in inviting Dr. Geeta Iyer, who needs no introduction for extensive work on ocular surface diseases, to present on a very important topic, that is the ocular chemical injuries, because the treatment of that is at primary care setting, and if that's not managed well, then that's where the tertiary care setting comes in. So the primary management and also the tertiary management is very, very important. Dr. Geeta Iyer.
A very good morning to one and all of you. Thank you, chairpersons, for your kind introduction and for this opportunity to speak on a very important topic of ocular chemical injuries. Today, I will be sharing certain newer insights into the management of chemical injuries, especially the acute chemical injury, and especially those belonging to the very severe grades where standard treatments often fall short. I have nil financial interests to declare. The primary goal in management of acute chemical injuries is to retain or regain limbal stem cell function and corneal clarity. This is largely achievable in mild to moderate injuries. However, in severe cases where significant limbal damage occurs, the conventional yardsticks of success, such as epithelial healing, symblepharon formation, the severity of limbal stem cell damage, corneal scarring, and the need for keratoplasty, are significantly delayed and high. Although amniotic membrane transplantation is widely accepted and favorable in moderate injuries, its role in severe chemical injuries is questionable. A review of literature that we did dating back to 2001, including the work by Dua et al. In 2001, followed by the Cochrane Database Systematic Review in 2012, followed by the randomized controlled trials from our very own RP Center here in India, or the randomized controlled trial by the Holland et al. Group, has always shown basically that the outcome of severe chemical injuries is very poor, and amniotic membrane does not accelerate the healing in patients with severe chemical injuries. Our own study of 38 severe grade chemical injury cases treated with amniotic membrane alone showed poor healing outcomes. And the reason for this is basically the fact that when you have a very large defect on the ocular surface, then the time that it takes for the epithelium to heal, especially when you do not have any residual cells on the epithelials on the ocular surface, is long, which leads to a non-healing epithelial defect, which in turn leads to sequelae of the same in the form of corneal scarring or corneal thinning, and sometimes even corneal perforation in the central part of the cornea. And this is where we basically highlighted the role of adding cells onto the ocular surface in the form of AIOS2025, which is what we introduced, the early stage allogenic simple limbal epithelial transplantation, to provide a cellular cover over the amniotic membrane, which aligned with Professor Dua's observations for the need to add cells in patients with severe chemical injuries. Retrospective analysis of our own series comparing AIOS2025 to amniotic membrane alone showed a significant improvement in all the yardsticks of success, as you can see here, whether it be the time to epithelialization or whether it be the severity of symblepharon that these patients developed or the severity of LSCD that these eyes developed following the use of AIOS2025 in severe chemical injuries, with a comparison of outcomes in the amniotic group alone versus the AIOS2025 group. The epithelial healing occurred almost 9 times faster with AIOS2025, and the odds of complete epithelial healing occurring within 30 days in the AIOS2025 group was 6 times more than just the amniotic membrane group. This basically highlights the importance of rapid epithelialization in acute chemical injury, especially in patients with severe grades, which can be effectively achieved with early stage AIOS2025 in chemical injuries. And this is basically our goal, to achieve quick epithelialization. Effective management ultimately requires an effective classification system. When you look at the existing grading systems for chemical injuries, the focus is primarily on the epithelial defect, but the epithelial defect which only involves the limbus and the conjunctiva and does not comprehensively capture the factors which influence outcomes, because epithelial defect is not the only parameter that affects the outcome in these eyes, and barely addresses what an ideal classification system should offer. So when you look at what the current grading systems offer in terms of the disease direct effects or any of the other parameters that give you an understanding of what the final outcome would be, we do not have a grading system that accurately captures most of these parameters. To bridge this gap, we proposed an algorithmic approach based on key influencing parameters, which we termed as the I's and E's of management, where you're not just looking at the epithelial defect, but also at the inciting agent, the inflammation, the ischemia, the intraocular pressure, and the exposure, all of which together have an impact on the rate of epithelial healing in these eyes and subsequently the final outcome in these patients. From this, we developed what is called as EPICS, an enhanced grading system for acute burns, which is what we published. And building on this, we have now created what is called as the D-code score for not just acute injuries, but also for chronic injuries. And in the acute burns, it evaluates the conjunctival as well as the corneal epithelial defect, the ocular surface ischemia, the digital tension, and the exposure. And this is a short video that highlights the various parameters that are actually captured online on this system, which is freely available to use at codeicare.org, where you have all the grading of every parameter that has an impact on the final outcome in chemical injuries, which is captured along with the demographics, which is what D stands for. And when you click on the evaluate, it gives you what is called as the code score. And this is the dynamic printout which can be taken for the patient as the healing evolves, and you will have an understanding of how the patient is basically responding to your treatment. This is the printout. It is more comprehensive than the existing classification systems. It integrates seamlessly into the EMR documentation, where you just need to upload the PDF. It actively guides treatment decisions, reducing complications from overlooked factors, and it reinforces the goal of returning to code 0, ensuring optimized recovery. It is freely accessible, and this is basically to highlight again and emphasize the importance of the D-code score, which is a comprehensive score generator for patients with acute chemical injuries. Why do we really need something like this? Because when you look at 2 patients of similar severity of chemical injury, one on the left and one on the right, the outcomes have been totally different because it depends on the laterality, it depends on the ischemia, it depends on the exposure and the intraocular pressure. Each of these parameters which need to be addressed appropriately and aggressively in the acute stage to ensure that you have a good outcome. Both of them ended up with a vision of 6.6 or 6.9 in their eye which was affected, but you can see that one required a keratoprosthesis with an Ahmad glaucoma valve with tenonplasty and AIOS in the acute stage versus another which was a unilateral injury which did not require any of these other measures. So when you look at the decode score in comparison with the current grading systems, it provides you information on most of the parameters that are lacking in the current grading systems, and it is the next logical step to the existing classification systems, is dynamic and it is user friendly. Not just for acute injuries, but the decode is also something that we have modified for the chronic ocular injuries, where decision making is largely based on the laterality as well as the tear status, in addition to the extent of limbal stem cell deficiency. And this was an algorithmic approach that we had published for unilateral total limbal stem cell deficiency following a chemical injury, and bilateral total limbal stem cell deficiency in the APJO, and this gives a very clear understanding of the algorithmic approach to these patients, especially in bilateral total limbal stem cell deficiency, where the decision needs to be taken with regards ocular surface reconstruction vis-a-vis keratoprosthesis, where again there is an algorithmic approach to choosing the right type of keratoprosthesis in every patient based on the anterior segment, the posterior segment details, the psychosocioeconomic factors, and the immunological condition of the patient. And this is a short video which shows how we grade the chronic ocular burns based on several parameters, which include the laterality, which again includes the CODE, where C stands for the conjunctival shrinkage. O basically represents all the factors which affect the circular limbus, which is not just your extent of limbal stem cell deficiency, but also your tear status, whether the surface is moist, dry, or keratinized. It also gives you an idea of what the digital tension is, and also allows you to give an estimate of what the visual potential could be in that particular eye based on the presence of glaucoma, RAPD, phthisis, the posterior segment status, and anything else which might compromise the visual potential in these patients, and therefore gives you a scoring which helps you counsel the patient as well as the family more effectively with regards the choices that you have for management, as well as the option or prognosticate with respect to the visual recovery in these patients. With the use of these kind of criteria for both acute as well as chemical injuries over the years, we today have several options even for end stage very severe grade chemical injuries, and this is to highlight some of our patients of chemical injuries whom we have been able to rehabilitate with the help of the various types of keratoprosthesis, the OKP or the type 2 or the type 1, where these patients have regained back visual potential to become self-ambulatory and to get back some amount of normalcy. After establishing Code Eye Care, an Institute of Excellence for cornea, ocular surface and dry eye in Chennai, we continue to follow up and take care of these patients with very severe bilateral end-stage ocular surface disorders, the type 2 K-pros, which we today have an experience of close to 88 keratoprosthesis, and the modified osteoodontokeratoprosthesis, where our cumulative experience stands at 131 cases so far. So to summarize, these are some of the newer insights into chemical injuries, where there is a role of AIOS in severe grade chemical injuries, and the decode scoring system, which helps us to grade not just acute chemical injuries, but also for chronic ocular injuries. And I would reiterate that these kind of grading systems are very essential to understand the existing status of the eye and the appropriate management in these patients. I would like to thank the entire team back home in Chennai at Code Eye Care, my work sibling, Dr. Bhaskar Srinivasan, and the entire team at Code Eye Care, our mentors, and our patients. And I would also like to take this opportunity to invite you all to the Keracon 2025, the annual meeting of the Cornea Society of India, to be held in Goa this December. Thank you.
Thank you, Geeta, for the insightful talk. As I said, we leave the questions till later on. Our next speaker is my co-chair, Professor Charles McGee from New Zealand, Auckland. He's going to speak on repairing and replacing the iris. So we pass the time to Charles.
Thank you. That was an excellent presentation, Geeta. I'm going to talk about, further down the line, talking about replacing the iris, particularly intracapsular, sulcus, and sutured artificial irises. I have no financial interest in anything I'm presenting. So how do we deal with iris defects? Well, we can use cosmetic contact lenses, dark glasses, corneal tattoo and peripheral lesions, iris sutures, intracapsular segments, sutured analytic IOLs. And what I'll concentrate most of my talk on artificial irises in various positions. Dark glasses are fairly straightforward, but you'll hear more about contact lenses later, but we can look at transparent tinting, opaque designs, and custom hand painted. This case here is just off-the-shelf contact lens, which works very well for this patient with Urette-Zevalier syndrome. Here's a case of floppy iris syndrome during phaco, extensive disruption of the iris. It's pretty threadbare, it's distorted, but relatively easy to fix with just 2 stitches using the 4-throw no-knot technique pioneered by Agarwal and others. What about artificial irises? They've been around longer than you might imagine, since the 1960s, and these images on your right are the various choice, as in Peter Choice, artificial irises with incorporated IOLs. However, they were largely unsuccessful because they were complicated by angle changes, UG syndrome, and corneal failure. Morcare, however, developed a large prosthetic PMMA IOL with a black aniridic iris surround, and it worked very well from 1990 until the last 5 or 6 years, when it was supplanted by the newer artificial irises. Optec also developed aniridic IOLs and segments in a variety of colors, and those colors were sometimes quite dramatic and actually drew attention rather than deflected from the defect. Volker, Rasch, and Morcher produced the first injectable prosthetic IOL, iris, and then Koch and Human Optics persevered to design a silicon unit, which is now widely used and actually had FDA approval in 2018. So these are some of the older, but still around, techniques. This is a variety of combined IOL artificial iris insertions. These are for aphakic guys with iris defects. The Optec lenses are above, the Morcare are below. I enjoyed putting these in over the years. You no longer have them readily available in most markets. So here we see a case with traumatic mydriasis, cataract, severe glare, and a corrected vision of 636, guarded prognosis due to blunt trauma. We did the cataract. You can see the edge of the rexus, inserted 2 iris segments, and then an IOL. And when the pupil is its normal size, you can see we've restored a fairly reasonable pupil size with 6/12 vision. These are slightly more difficult to put in, but through a smaller incision, 2 segments which interdigitate, in this case, another blunt trauma case, and we successfully reduced the pupil from around about 9 millimeters to 4 millimeters. You always have to preserve any tissue you have. In this case, the lens is being held up in part by superior zonules and the iris segment that remains. In fact, the pupil is at the very bottom of the screen. But here again, you can do a cataract. We put in thin segments. We didn't want to stretch the bag too much. And this patient got a 6 millimeter pupil and restored visual acuity. Suture down aniridic IOLs require a big incision. They work very well in those who've had severe trauma and have lost most of the iris and the vitreous. It's a globe rupture, one of the first ones I did in 2003. I saw this patient early last year, and he still maintains 6/9 vision 20 years down the track. The main issue here is using a no-touch technique with your sutures, or the Prolene won't last. But even so, 20 years for Prolene is pretty good. However, in 2011, I changed the way I started doing these and looked at new approaches and started using artificial irides. This is one of my first cases. Severe trauma, retinal detachment, macular hemorrhage, good peripheral vision but no central vision. It's a very guarded prognosis but suffered severe glare. I went ahead and sutured in an IOL and an artificial iris, and she was happy with the result. What is the human optics artificial iris? I have no interest in this fiscally. It's a pigmented silicone design. It's either got fibre if you want to stitch it, or no fibre if you want to put it in the bag or the sulcus. You can get it bespoke to match the pupil, the iris colour of the opposite eye, or you can get an off-the-shelf one as a standard colour. It can be folded or injected. You can put it in 3 main positions: sulcus, endocapsular, or suture to the sclera. It was FDA approved in 2018. What we've done this is data in December. We've done a few more. With 75 eyes in New Zealand, about 64 in Auckland, and 54 with my team. Why we're mainly doing them and how we're doing them? Well, mainly we're putting them in the bag. We're not doing so many sutured or sulcus-based. The indication, largely trauma, but also excision of iris tumour, since we are the country's centre for excision of iris melanoma. Clearly, these are not designed to change iris colour. This is a major intervention. We use a mite incision when removing the iris tumours, minimal iris touch excisions. You use 4 1mm incisions, 1 standard phaco incision, and you can remove most tumours from the eye this way, leaving it suitable to then go ahead, depending on the histology, with reconstruction. Here's one of our early cases. The lens is already in the bag. We've folded the artificial iris. This is a melanoma excision before. You have to center the lens well, because once the iris is in, it's more difficult. So we've centered the lens. We've got the iris in the bag. Then obviously remove all viscoelastic. And post-operatively, it looks pretty good compared to preoperative. But further down the line, one of the beauties is you can see into the angle still. You can still see the ciliary processes. By putting the artificial iris in the bag, you're enabled to continue to observe the case. This patient also had proton beam therapy because it was a high-risk tumour with a little residual peripheral iris there. But at 8 years, the patient was still seeing 6, 7.5. What is the standard technique? Well, standard phaco of your choice, 2 paracentesis incisions. You need to stain the capsule well so you can see it when you're inserting. You need a larger capsular X, about 6 millimeters. Again, center the lens before you unfold the iris. So we're centering the lens there. Then we let the iris unfold. We're using second instrument to keep the iris folded. Unfold 1 leaf and keep the iris pressed back into the bag. Then we use a second instrument to unfold the second leaf. And often the only significant manipulation is the trailing edge. If the trailing edge doesn't go in properly, in which case you have to fold it into the bag, or you can pull it into the bag. And it's critical that the iris is entirely in the bag, or it will vault forward. This is an aniridia. This is a bilateral congenital aniridic, overwear contact lenses, plus vascularization, plus early limbostem cell compromise. So we did bilateral clear lens extraction with the iris in the bag. Here we're using a second instrument, a microforceps, to pull on the trailing edge to place it in the bag. And again, in this case, you can actually see the well-stained capsule is covering it's covering all of the periphery of the iris. What does it look like? This is day 1 in the right eye. You can see the pupil is not quite perfect shape because we've retained 70% of the patient's iris. This patient obtained 6/6 vision. You can also put in scleral sutured iris IOL. You can either use a belt loop technique to attach the three-piece lens to the iris and then suture in or otherwise fixate the iris. Or you can actually physically stitch the lens to the iris and then suture in the iris to sclera. And you can see in these cases, these are complex cases requiring pars plana vitrectomy. One of the easier ones, this is Urezza Valier following a glaucoma procedure. They had very high pressure, the pupil is enormous. We have already had a cataract procedure performed at the time of the glaucoma procedure. And we went ahead, matched the iris for color, and inserted an artificial iris into the sulcus. We also did an ultra-thin DSEC, and the patient achieved 6/6 corrected vision at 2 months. Here are some other examples of irises seen up close, where we've put in artificial irises. D is day one with a very complex iris pattern, which is well matched by a bespoke iris. These patients generally do well. Of course, you do have some complications. If we look at the first 19 cases of in the bag, with more than 14 months follow-up, there were no lines lost of best corrected visual acuity. Overall satisfaction was high. There were some mild or self-limiting complications. Obviously, an IOP spike, you need a lot of viscoelastic to do this. Cystoid macular edema was more common, being about up to 15%. And that's probably because these patients have had trauma or iris surgery before they go on to have artificial iris surgery. The only moderate complication we had was one vaulting of prosthesis. Now that we've done more than 60, we've had 2 prostheses vault. You do put in a CTR at the time to try and keep the capsule in tension. But in these cases, you can trim the iris and put a suture in and leave it in the bag. I think one of the main things to note is the instant loss of accommodation in younger patients is really notable. So we're now considering we should put an EDOF lens in for those patients under 40. So how would we summarize this? Always consider, always consider conservative approaches. Tinted lenses work well, spectacles work well. Focal loss may work well with a peripheral corneal tattoo. If the iris is viable and not too scarred, you may be able to repair it by suturing it. Anaeritic IOLs and iris segments are no longer available in many markets, unfortunately. Artificial irides are suitable for insertion with IOLs in the sulcus, in the bag, and scleral sutured. Beware of cystoid macular edema and low-grade uveitis. These patients need to be on topical steroids for 2 to 3 months. And acute presbyopia impinges on satisfaction. Only remains to thank the many colleagues, both consultant and the many fellows who've worked on many of these projects over the years. And thank you for your attention.
Thank you, Dr. Professor Gee, for those wonderful surgeries and on the bespoke iris. So it gives me great pleasure in introducing Dr. Julia Chan, who's from the Chinese University of Hong Kong. She's an assistant professor out there with extensive knowledge on the epidemiology. And she's going to talk to us about solar damage. Being in the Asia-Pacific region, solar exposures are much more. And we do see a lot of solar surface damages like pterygium, which is more common, nuclear sclerosis. And sometimes we get a lot of patients in whom we don't exactly have a diagnosis, but one of the risk factors are solar exposure. Dr. Chan.
Thank you so much for the kind introduction. Solar damage is a very serious problem, particularly in Hong Kong. In the following, I'm going to illustrate a case series of photokeratitis outbreak in Hong Kong 2 years ago. I have no relevant financial disclosure. So I would like to acknowledge my chairman seniors and my support from Hong Kong in making this presentation possible. So photokeratitis is a type of acute inflammation of the cornea related to ultraviolet radiation light exposure. Depending on the UVA, UVB, or UVC. This will cause epithelial haze, stromal haze, corneal edema, or even penetrate inwards towards affecting the lens. So as I have mentioned earlier, a quick recap on physics. We know that electromagnetic wave manifest according to different wavelengths. And beyond visible lights, we can see a lot of UVA, UVB, and UVC, and this will depend and if penetrate into our eye, will cause a lot of severe problems. This illustrates that UVC will primarily affects the epithelium of the eyes, while UVB might penetrate into the anterior chamber, and UVA, with the longest wavelength among the three, will cause damage to the lens. And the maximal spectral responsivity will be affecting at around 288 nanometers. So how do we get ultraviolet C radiation in the environment? Because all the ultraviolet C radiation from the cosmos, from the universe, has already been absorbed by the atmosphere. So all the UVCs affecting humans' eyes are those that are man-made, which can be classified into recreational, disinfecting devices, and others. So a look back at the masked photokeratitis in literature, we can find that there are multiple causes that are at risk. For example, in nightclubs with improper installments of UVC lights as purple lights, in hospital coronary angiography units where the disinfecting facilities incorrectly emits UVC lights, in gymnasiums, in restaurants, even in livestock auction house. And the commercially available COVID-19 pandemic lights are also causing photokeratitis in patients. So this was in literature where the disinfection slide door of the apron disinfecting systems does not close appropriately. It was intended that when the doors are closed, the lights will turn off, but instead it doesn't. So that's why it causes a mass photokeratitis in a Korean cohort. So how does photokeratitis manifest? It does not only affect the patient's ocular surface, but also affects the skin as well, mimicking those of a sunburn. This is a patient present to me a few months ago with wielding by himself without any protections at all, complaining of severe tearing, eye pain, and also an obvious skin burn. And this is his presentation to me one day after the condition. So let me carry on the photokeratitis mass outbreak in Hong Kong 2 years ago. In 2023, in November, there was a spike of 8 patients suddenly seek medical attention, all complaining of eye symptoms. All of them have a common exposure of an outdoor event from 5 p.m. to 11 p.m. on the day of November the 4th, 2023, where there was an event held at the Kai Tak Cruise Terminal, where the airport was previously situated in Hong Kong. So the patient's demographics are listed below. You can find that the mixed ethnicity in this cohort, because it was an international event back then. And you can see that the age of the affected patients are relatively young. And as you can see, for the duration of exposure, there is the duration of exposure is around 3 hours, and the presentations was far delayed until 8 hours after the event. And you can see that only 3 patients were wearing contact lenses at that time. And none of them are wearing any protective tinted spectacles because it's an event at night. The clinical presentations of this cohort complained of very common eye irritation symptoms ranging from eye pain, red eye, photophobia, tearing, and there's no specific laterality difference in terms of visual acuity on presentation. These are the other clinical literature, how photokeratitis was documented in literature. And as you can see that all the patients will present in similar ways as it is. So majority of the patients presented to the emergency department because it was late at night, and often being assessed by emergency department colleagues only. At that time, a majority of them suffers from corneal and conjunctival involvement, but none of them has manifestation over the anterior chamber. Depending on who they attended, some of the A&E doctors even prescribe patients with antihistamine, thinking that it's an acute case of allergic conjunctivitis. So I would like to illustrate further with a case of photokeratitis in one of the 8 patients who presented to me later. It is a 40-year-old female who complained of both eyes redness and pain for 4 hours. She has been on regular contact lens use and using daily contact lens for 12 hours wear each day. When she attended the event at the Kaita Cruise Terminal, she was exposed to an indoor display room, documented over here, where there's a dimension of a quite small room, 4 times 6 meters square, and staying there for 20 minutes for some photo taking and uploading it into the Instagram or other social media. And these are the actual pictures taken by the patient herself. As you can see, that is very apparent that those displays all demonstrate fluoresceins. And then, after the event of taking pictures in an enclosed function, they proceed forward to an outdoor event concert where they were 3 meters away from the stage and stayed there for 3 hours. So, at the midnight, she attended the emergency department for severe tenderness. Her vision was maintained well, but then there's ciliary vasodilation and staining was negative for them. And the A&E department prescribed her with painkillers and also some antibiotics. She attended tertiary eye surface on day 3 for follow-up. By that time she attended, the conjunctiva is already white, and there is absent of any other corneal manifestation as well as lens manifestation, and she was prescribed with lubricants. And this is the particular patient I have been mentioned, and you can see that by the time she attended me on day 10, all the symptoms have been resolved, and also the tear breakup time of the eyes are maintained, and also speculum microscopy performed on that day showed no changes in normal cell density in these kinds of patients. And the same is on the fellow eye. So, this mass photokeratitis was brought into the attention of mass media, and this was published and covered in majority of newspapers. So, to conclude, this was indeed, looking back into literature, was not the only time when there was a mass photokeratitis outbreak in Hong Kong. Looking back a few years ago, in 2008, there was another outbreak where the organizer of the exhibits did something wrong by introducing the UVC lights and still it again for a public function. So, thank you for your kind attention, and this is a presentation of me illustrating the first documented in literature to document symptoms, signs, and clinical course of mass photokeratitis for recreational purpose. There is a dire need for regulation on UV emitting device and to prevent further situations from happening again. So before I conclude my presentation, I would like to all invite you not only to the APAO 2026 in Hong Kong, but also save the date for our ACS, which will be held in the same year, but in December 2026. Thank you so much.
Thank you very much. We'll take questions at the end.
Thank you.
It's a great pleasure to introduce one of my colleagues, Dr. Akhilesh Gokul, who's a vision scientist from the University of Auckland. Aki is an international expert on collagen cross-linking, keratoconus, and contact lenses. And today he's going to talk about contact lenses.
Thank you for the introduction, Charles. So my name's Aki. I'm a senior lecturer at the University of Auckland, and as Charles mentioned, a practicing optometrist specializing in contact lenses. So we're speaking about, in this session on trauma, how contact lenses can be used in management of ocular trauma. I have no financial disclosures. So Contact lenses are indicated essentially following primary repair or secondary repair from a traumatic event. It can be used to provide visual rehabilitation without the requirement of further surgery, or it can delay further surgery so that the patient can function while they recover to a point where they can have an additional operation to restore vision without the use of a contact lens. Of course, in cases of trauma, you can have unforeseen complications during secondary repairs and things like that. Sympathetic ophthalmia is always a risk. And also we want to prevent or delay the need of corneal transplantation since it's associated with much morbidity. Blunt force trauma or bursting type injuries, the primary repair can cause corneal irregularity, and it can also damage the iris and the lens itself, so the trauma itself. The repair can result in iris defect with enlarged pupil. It can also have the lens damage. These patients can be left aphakic with a high refractive error, and of course, IOL calculations are difficult in these patients. They can be left with a high amount of anisometropia or antimetropia. Penetrating eye injuries depends where the penetration occurs, whether it's through the cornea or the conjunctiva, but the net result is the same. The primary repair can result in corneal irregularity and damage to the iris, and iris or lens itself can result in aphakia and iris defects as well. Of course, the retina must be intact in order for a contact lens to function properly. There are many types of contact lenses available in the modern world. Soft contact lenses are the most commonly typed use of contact lens for the correction of ametropia. These can range from daily disposables to fortnightlies, monthlies, and custom contact lenses as well. These can have artificial irises or a colored contact lens. Hard contact lenses or rigid contact lenses also have a wide array of different lenses available to us, ranging from an RGP, a small hard contact lens, all the way to a large scleral contact lens. So first of all, looking at how we can address corneal irregularity following trauma. This is done with a rigid contact lens. So it's important to understand how this works. So of course, the rigid contact lens remains its own shape on the eye, maintains its shape. The fluid or tear film layer behind the contact lens effectively fills in the irregularity. So the hard contact lens acts as a mask, effectively creating a new front surface for the eye, and hence the eye can function like a normal eye once again. Depending on the level of irregularity, we should consider different options. If it's a mildly irregular cornea, you can use spectacles or a soft contact lens if the vision achieved is better than 6/12. If there's moderate irregularity, we should consider things like RGPs or small hard contact lenses, but you can consider the whole gamut of contact lens options available. Effectively, what we need is to look at sagittal heights. That's how much irregularity a contact lens can correct. So an RGP being a small lens can only have a small sagittal height, so it can only correct mild irregularity. More severe irregularities need effectively bigger contact lenses, which have a bigger sagittal height, which can then correct for the irregularity. We'll go through a few cases of patients that had irregular corneas following trauma and how these were managed. So we have a 40-year-old male. When he was younger, packaging strap snapped and it penetrated his cornea of the left eye, damaging the iris and lens as well. The primary repair encompassed just suturing the cornea back together. We can see in the image there, there's a suture that remains within the cornea many years later. It's well buried, so it didn't need to be removed. The secondary repair included a phocoemulsification and intraocular IOL, intracapsular IOL. The iris damage was minimal, so no further repair was required. So look at the patient's spectacle refraction. We can see the right eye, the undamaged eye, corrects very well, 6/6 with a moderate amount of myopia there. But the left eye only corrects to 6/12 because of the corneal irregularities. In this case, the main limitation to the patient's vision is the irregular cornea. So healthy retina and a clear IOL. So we look at the patient there clinically, we can see that there is a slightly distorted pupil shape, but it looks fairly good overall, still responds to light. We can see that the trauma repair was down the bottom here. The astigmatism looks fairly regular when you overlay the topography over the iris image, and you can see the iris atrophy there on the temporal side where the injury occurred. In this case, the patient was fitted with a rigid contact lens, an RGP, a small contact lens of 9.5 millimeters in diameter, small refractive error there, and correct the patient up to 6/6. So high utility in this patient who would otherwise be left visually impaired in this eye. Case number 2 is of a corneal laceration. Once again, this is an 80-year-old male, had a non-penetrating corneal injury in childhood that was repaired, but is left with poor vision through the rest of his life. In his later years, he underwent age-related cataract surgery, but the poor vision persisted as the cornea was distorted. So clinically here, we can see from his refraction, his left eye, the good eye, corrects that very well with a small amount of myopia, but the right eye, despite a high level of astigmatic correction, was poor vision at only 6/18. And as you can see from his corneal tomography, he's got a lot of irregularity in his cornea. This is a moderate amount of irregularity. So the main issue here was the irregularity once again. And once again, we can see here from the clinical image here the scar through the center of the cornea where the injury occurred. You can see that results in an irregular cornea over the pupil. In this case, the patient was fitted with a semi-scleral contact lens, a big, hard contact lens. This was chosen because of the level of irregularity, but also the level of comfort. These tend to be much more comfortable than the small lenses, and is able to restore visual function fantastically. As you can see, this patient was 6/7.5 with this lens in place. So moving on to addressing anisometropia or antimetropia when there's an iris defect as well following trauma. We usually use a soft contact lens for this. The cornea usually remains a regular shape, so you can use a soft contact lens. They have a large power range in the modern world. Theoretically, any sphere still can be corrected with a custom-made soft contact lens. The colored contact lenses have an artificial iris. You can have the standard ones, which are available for cosmetic purposes, but they work quite well for these patients as well. They're more comfortable because they're a lens that was replaced more frequently, either daily or monthly. But you can get a custom contact lens, which is almost exclusively for iris defects. They have a black backing to them, so they control glare much better than the standard cosmetic contact lenses because they have a clear backing to them. These are less comfortable. They are replaced only every 6 to 12 months, so the material is more stiff effectively, making it less comfortable for patients to wear. So case number 3 here is a penetrating eye injury once again. This was through the cornea. A 29-year-old male had a metal foreign body go through his cornea, damaging the iris and lens as well. So the primary repair was just that of suturing the cornea back together. Secondary repair was more extensive. There's a corneal wound revision, phaco, and this patient was left aphakic in this case. They did not put an intraocular lens in to start with, and there was a vitrectomy performed as well. As you can see, it's quite a complex case. You also end up with secondary ocular hypertension from the trauma. So we'll look at his case. Spectacle refraction-wise, you can see his left eye has almost no refractive error. It's emmetropic, whereas right eye is very hyperopic with a bit of astigmatism resulting from the aphakia and also the primary repair. Fortunately, you can see that his cornea is quite regular. The primary repair left him with a moderate amount of against the rule astigmatism, but it corrected up very well with the spectacle refraction. Of course, this is not practical, so the patient did need a contact lens in the end. Interestingly, it was not very photophobic, despite having a very large iris defect. So clinically here we can see that it has a very big iris defect here, very large pupil, and its primary repair was located temporarily here on the right side. And when you overlay the topography once again, you can see that as a very regular topography, so a soft contact lens can work for this patient. So in his case, we went for a clear custom-made soft contact lens with a very high refractive power included, which corrected his vision up perfectly. So we did not use a colored contact lens in this case because he didn't need it. He didn't have very much photophobia, fortunately. Case number 4 is once again a penetrating eye injury. This time it was not through the cornea. A high-pressure hole struck the patient in the eye. It's a bursting type injury near the limbus, damaged the iris and lens as well, but not the cornea directly. So the primary repair was to re-establish globe integrity and also removal of the damaged part of the iris and phacoemulsification and an IOL as well. So this person, fortunately, had a relatively regular cornea, despite it looking quite irregular there. We'll see in a second the part it looks through is quite regular. So he had high amount of anisometropia, which is the main limitation to his vision, as well as the extreme amount of photophobia due to the large iris defect. So as you can see there, through the center of his pupil, his vision is quite good because his astigmatism is quite regular. In his case, we used a standard colored soft contact lens over-the-counter type deal, and as you can see, it's clear there, but it provided significant improvements to his photophobia and corrected his vision to 6/7.5. Final case here is another interesting case with penetrating injury through this conjunctival sclera, 59-year-old male with a bungee cord damaging his eye. Primary repair encompassed re-establishing globe integrity, but he was left aphakic once again. So he had, again, a very regular cornea, but he had a high refractive error. You can see the left eye there was +11 with a -2 astigmatism. Extreme photophobia once again due to the very large iris defect. But the minimum amount of corneal irregularity through the center there meant he could use a soft contact lens. So he was fitted with a custom soft contact lens, which has a black backing to it, which dealt with the refractive error much better, but also the photophobia as well. So in his case, 6/7.5 once again. In this case, the patient wore the lens for about 2 years, then underwent a secondary surgery, which included a sutured IOL and a sutured artificial iris implant. His refractive area still ended up quite anisometropic, so he's back in soft contact lenses ultimately, but these were standard soft contact lenses. So in summary, contact lenses are very effective at restoring visual function post-surgical repair or healing from ocular trauma, so should be considered where possible because it is a very conservative approach and allows the patient to function normally. They can be used long-term as the primary form of visual correction or as an interim measure while waiting for the eye to heal or settle before having a secondary or tertiary surgery performed. Widget contact lenses are highly useful in patients that have corneal irregularity, and they can prevent or delay corneal transplantation altogether. Soft contact lenses are highly effective at addressing anisometropia when there's minimal corneal irregularity, and they can have an artificial iris as well when there's an iris defect, which can be excellent at addressing photophobia. Thank you for your attention. I'd like to acknowledge my mentors as well as the contact lens manufacturer in New Zealand who provides these contact lenses. Thank you very much.
So we have a video from the last speaker, Professor Wei Li Chen, which will be on the corneal trauma in patients undergoing refractive surgery. Is the video not there?
Do we have a video for the last speaker?
Is the hall manager here?
No video. Okay,
video.
so that gives us time for an exhaustive question and answer. Could the other speakers come back up, and we can all be up here, and then you can all ask questions. There are 4 microphones, but if the speakers could come back on stage, please. And that was a wide-ranging discussion of trauma, and we will take questions from the floor. If not, we'll take questions from the panel.
Hi, Prof. McGee. I'm Cam from Hong Kong. I have a question for you, one of your patients. You show us a patient number 4 who had a mulch.
You need to speak up a little bit.
You're too tall. Thank you for your talk. You showed a patient with a residual iris stump, case number 4, that you decided to take away the stump. But in some of the patients, you don't take away the stump.
Yeah.
What's your thinking process
And
when you take it?
yeah, I would agree. Usually you try and leave the iris unless it's jammed in the wound or if it's involving the angle. In this case, the patient had a 11 clock hour dialysis and had the whole iris and the pupil from 1 clock hour. I think the risk of that becoming necrotic with time was very, very high. But generally, I'd leave all of the iris that I can, unless it's compromising the angle. So that was almost unique, and if I had a longer time, I'd have shown the video, because we removed that bit of iris, then we examined the retina and found there's a giant retinal tear as well. So it was a very complex case, and he's done very well, fortunately.
I see, thank you. And I have one more question for Dr. Gita as well. It's a question about the first presenter's PowerPoint, the me-her keratoprosthesis. In the conventional MOOKP, you wait for the eye for the tooth to develop before you go in to implant the cylinder. What's your view about doing it single stage? Any concerns about doing the K-Pro in a single stage rather than waiting for a second stage?
Thanks, Cam. So the need to wait for the second stage for the tooth is for it to develop its vascular supply. It cannot be implanted directly into the eye. Vis-a-vis the Boston type 2 keratoprosthesis or the MECOF, I've heard Professor Wang deliver this lecture a couple of times earlier, and I've interacted with her. For these kind of procedures, especially where you're using only the auricular cartilage, it is not essential that you need to do it as a double-staged procedure. You will still have a good outcome even if you do it as a single-staged procedure, because it's not like the cartilage is going to just necrose off due to the lack of vascularity.
Dr. Geeta, if I may ask on the same line, in low resource settings, and you work in a low resource setting, what are the challenges that you mostly face in the follow-up of these patients from the primary time they present and lastly? And also, can you stress, because maybe some of them would be in a primary care setting, on the importance of the first intervention that an ophthalmologist gets when a patient with an acute, maybe Lyme injury comes? Because Lyme injury is very common around.
Yes, so Lyme injury is something that's very peculiar to the Indian scenario, where it's basically the edible lime that goes and gets stuck, especially under the upper eyelid in the superior fornix. Unlike other chemical injuries, it's very difficult to remove this lime, especially when you're in the OP. And therefore, most of these patients, especially children, and in fact even some of the adults, would need to be subjected to an immediate exam under anesthesia, under general anesthesia, because you will not believe how difficult it is to get rid of these chunks of lime particles from under the upper lid if you try to remove it in the outpatient. And therefore, it is mandatory that these patients are taken up for an examination under anesthesia. When you mentioned low resource, I am not sure whether subjecting a child or a patient to general anesthesia would be difficult in those settings. And if it is, then the patient needs to be subjected to copious irrigation and referred to a higher center where the patient can be subjected to examination under general anesthesia. We had this child who arrived within 18 hours of the injury. So sometimes even if we are able to assess these children within the first 24 to 48 hours and we are able to get rid of significant amount of Lyme, it does help. Therefore, I think it's important to create awareness amongst ophthalmologists across the country about the parameters which have an impact on the final outcome. Because what happens is that so many times these patients are taken care of and the only parameter which is addressed is the epithelial defect. So you end up putting a bandage contact lens, and since we do now have the availability of the amnion graft in several places, we do keep performing amniotic membrane grafts. But a Lyme injury invariably ends up causing a grade 5 or a grade 6 chemical injury, in which case it is almost impossible for just the amniotic membrane to help in the epithelialization occurring on the ocular surface. You could have an exposure, you could have raised intraocular pressure, and unless we create awareness that all these factors have to be addressed in the acute stage, there is no point in having an epithelialized surface in an eye that you have lost to glaucomatous optic nerve damage. If you end up with a nil perception of light, there's nothing that you're going to be able to offer for visual rehabilitation. So when you tick on the check boxes, which clearly indicate to you what are the parameters, which is why we thought it would be simple to have something called as the I's and E's, whereby it is impossible for you to miss out on the parameters that need to be addressed in the acute stage. So you have to copiously irrigate. Whatever might be the irrigating fluid is fine. It could be tap water where the injury occurs, or it could be any of the fluids that you have that is easily accessible to you. You don't have to feel that you don't have a buffered solution or you don't have any of the specific irrigating fluids. Just copiously irrigate and get the pH to neutral. So these are small things that can be done at by any ophthalmologist, irrespective of the resources that you have, so that you address these factors. In acid injuries, what happens is you end up having an exposure. A simple tarsorrhaphy can be done to prevent exposure-related perforation, because these are eyes that we see a month after the injury has occurred with chronic exposure, and you end up having a perforation just because the exposure has not been addressed. It is with this very aim that we have created what is called as the DECODE score, so that any ophthalmologist who's sitting in any part of the country or the world will first primarily be aware of the factors that need to be addressed and make sure that if it is within his or her resources to address these factors, please go ahead and do it. And if you do not have these resources, refer the patient to the next center that will be able to offer these solutions.
I think very important points highlighted on glaucoma, getting all those particles out. Professor McGee, what kind of chemical injuries do you see in your clinic in Auckland?
We see a lot of chemical injuries, but not to the same severity as Gita. The probably average time to get to treatment in our practice will be under 90 minutes. And everyone's pretty well informed. I would suspect that the vast majority of irrigation, wherever they present before they come to the centre. So we published recently on our outcomes and did pretty well. The number that we need to do limbal stem cell transplants pretty low. It would be less than 10%. But we've got a fairly comprehensive, at our accident emergency service, a flow chart. Not as good as yours, but similar, where you go through the whole system. I'm now going to employ yours. I thought the decode was excellent, really excellent. One of the things I wondered was, so you can access this online, do you collect the data when people access online? I mean, do you have an analysis function?
So at this point in time, both with the Asia Cornea Society as well as with the APAO, we are trying to see if we can have multiple ophthalmologists use this particular scoring system so that we can actually collate the data. But amongst the data that we have had among few ophthalmologists who have used this score, what we have understood is that it definitely helps in directing management in the right direction. Yes. But we don't still have a huge data that we can publish. In fact, if I could actually propose that if we could have, the cornea specialists as well as general ophthalmologists in the Asia Pacific area use the system, because this is one region, geographical region in the world where we do see more of chemical injuries, including vitrillage. We could actually help channelize. We could also take feedback and help refine the system if there is any need to do so.
Okay, my turn. For the first talk, I had the pleasure to actually, in China, the largest series and the national center is actually in Beijing, is an army hospital. I can't remember the name of it. And I've actually visited Professor Wang's unit. It's pretty amazing. The results are very good. They published it in BJO, I can't remember, a few years ago, the largest series in the world, and very long-term outcomes are excellent. However, we've never tried it. Basically, I think it's the cost, I was just saying to Charles, maybe a bit prohibitive. If I'm right, it's over $10,000. We went to the store in World Corneal Congress in DC 2 weeks ago, and we spoke to the drug reps there, and they quoted us the price for a piece is over $10,000, which is prohibitive. I have a few questions for Geeta, the world expert in keratoprosthesis. Have you ever tried those, number one? Number two, in terms of the acute phase during the AIOS, my limited understanding of in the older days when you do the full limbal graft, they don't really tick well in the acute stage. How do these AIOS at the same time for these acute injuries do in the longer term? That's the second question. And then the third one, actually I have 4 questions, sorry. The decode is excellent. I've listened to your talks a few times already. It's a brilliant thing. It's basically a matrix score. But how do you decide the parameters in terms of weighting in the various different parameters? And then the last question is on Charles' one. If we use it, what about privacy issues? Because, data privacy and all that sort of thing.
Yeah, I think I remember all 4 of them. I did the same thing. We were particular. I mean, we believe very strongly that we should have all types of keratoprostheses that are currently being used and have published good outcomes. We should have access to all of them, because you never know which patient would actually be a suitable candidate for which keratoprosthesis. And with that in mind, I did the same thing. I went to the WCC stall. We tried to see if we could actually, yes. But yes, it is at this point in time prohibitively expensive, but they assure that the costs will be reduced. So I think we will have to wait for that day to actually be able to use that outside of China. That is as far as that question is concerned. The second was related to the scoring system. The weightage, I think that was the last, but you wanted to know about the outcome of AIOS. The limbal graft that was classically done earlier was placed at the limbus, and in eyes not in acute chemical injury. This was done as a part of the process of visual rehabilitation. So the difference between placing the allograft at the limbus versus the AIOS on the avascular cornea is that Just like slit works on the avascular cornea by the epithelial fronds growing out from the slit bit that is placed on the cornea, similarly, when you do the AIOS in acute chemical injury, you're placing it on the avascular cornea where the fronds do grow out of the slit bit. It is not being placed at the limbus. You could have an associated ischemia for which we combine it with a tenonplasty. We place the amniotic membrane on top of the tenonplasty and then we place the slit bits on the avascular cornea. Once you have the cornea epithelialized, you would see a significant amount of reduction in the inflammation, and the triggers for symblepharon also reduces. In fact, we've seen a significant decrease in the amount of symblepharon that you see in these patients. So to answer your question, placing these bits on the cornea vis-a-vis as an allograft at the limbus, we've never done that in acute chemical injury, but we believe the AIOS is something that would definitely, it works. Similar to how it works in an auto-slit in patients where you are taking them up for rehabilitation. We also do not subject these patients to immunosuppression during the acute stage of chemical injury, because your aim is not to have these cells live forever. It's only to get a quick epithelial cover in the acute phase and subsequently take up these patients for an auto-slit if there is a failure and if there is a reappearance of limbal stem cell deficiency in these eyes. So unless it's a bilateral acute chemical injury where you're doing an AIOS, we don't subject these patients to immunosuppression. As far as the weightage of these parameters is concerned, it's based on our experience over the years. These are parameters, if you look at any of the publications related to chemical injury, these are parameters that have been mentioned. The only thing is, unlike the TNM classification, which is what we always like to compare any grading system with, we believe that including all these parameters which are a consequence of the direct effect of the chemical injury and which have an impact on the final prognosis, it helps us manage these patients more effectively and prevent the loss of these eyes to other complications. So if you look at IOP or the ischemia or the exposure, these are all factors that are present in even Wagner's paper on chemical injuries. It's just that they've not all been grouped together under one broad umbrella of grading system, which I believe is the need of the hour and is probably something that is going to bridge the gap that currently exists in the grading system of chemical injuries to improve your prognosis in these patients. Because today we have options that can help a severe grade chemical injury regain a vision of 6/6. But if you have addressed the acute chemical injury well in the acute stage, only then will you be able to give back vision in the later stages of the course of the patient. And to address your last question regarding the privacy, yes, at this we are not officially collecting the data of any patient unless and until you give us the approval to do so. So anybody who uses it, we don't really have any access to the data. You can use it for your patient, and it's a dynamic grading system wherein you can fill up the data, including the pictures, so that you have a pictorial representation of the eye on every day during the follow-up for comparison, as well as have it accessible to even the next person who's going to be taking care of the patient in case the patient is referred to a higher center.
Thank you, Dr. Geeta, for this thing. Any questions from the house? Professor McGee, 2 questions for those iris implants, the bespoke ones. One is how difficult it is to put those inside the bag. And the second is, have you had experience of the pigments leaching out? Because in some of these iris implants, these implants reach out, and over time there's a fading of the pigment, and that results in secondary glaucoma and also low-grade uveitis. In
terms of difficulty putting them in the bag, they're not particularly difficult. I think you need to do a big rhexis. In my early ones, I tried to put them through a 5mm rhexis, and that's quite difficult. I think if you have a 6mm rhexis, they're not too bad. I teach fellows to do it, and I must say you can sometimes spend 5 minutes trying to get it in. Normally it would take you 1 or 2 minutes, but getting most of the iris in initially and keeping it controlled while you manipulate the IOL and then unfolding it, you're usually left with one trailing edge sticking out, and you can either fold it with two instruments or go in directly opposite and pull the trailing edge in. And as long as you've got that system in your head, how you're going to get it in, they're not too bad. In terms of leaching pigment, I think with the modern ones, these silastic ones, it's not been documented as a big problem. In terms of leaching, I've only been looking at these for about 10 years, but I've not seen any fading, and obviously New Zealand's a very high UV country. So I think probably when you look at the earlier models, there's quite a lot of variation. And there are other options around. Haven't mentioned them all because my experience is with one, but I have no interest in that company or the product. But I think with that, it seems to be pretty good.
Thank you.
I wonder if I could ask Akhilesh a question. One of the issues that corneal surgeons always worry about is putting contact lenses on eyes that have been damaged, and the risk of getting neovascularization or further scarring or Saltzmanoid type changes because of rubbing. So 2-point question. One, what percentage of the eyes that you referred do you think go into soft lenses? And two, in fact, it's a 3-point question. One, how many go into soft lenses? Two, presumably with your semi-scleral lenses, you're not going to get neovascularization even at the limbus, or will you get neovascularization at limbus? And three, have you seen corneal opacity with contact lenses getting worse?
So the first question about soft contact lenses versus hard contact lenses, the vast majority of patients coming through these days, fortunately, can be fitted with a soft contact lens. So it's probably about an 80-20 split, so 80% soft, 20% hard. So that's great these days. With regards to neovascularization, modern contact lens materials are very, very breathable. They actually have a decay or oxygen transmissibility higher than your tear film. So neovascularization is very uncommon unless the lens is poorly fitted and you get inflammation. That's the only time you get neovasc. With scleral contact lenses and opacification, things like that, it's not really, doesn't really occur these days unless the lens is fitted poorly. So it comes a lot down to practitioner skill. So if you're fitting a contact lens poorly, there's lots of rubbing of the lens on the cornea, you will get opacity and Salzmann's nodules and things like that. Modern contact lenses are actually fitted using topography. So the topography itself is used to make the lens custom fit to that corneal shape. So modern lenses are really, really quite impressive with that.
And is that fairly standard, that a lot of lenses are made directly from?
No, you have to have the device to do it.
Yeah.
So in a developing nation, you probably wouldn't have access to tools like that, but in New Zealand, we're obviously quite developed, and we have access to.
And if you vault a scleral or semi-scleral too much, does it make any difference?
Yes. Yeah, then you'll get neovasc. Because then your tear film becomes the limiting factor, not the lens itself.
Right.
So if your tear film's too thick underneath the contact lens, that starves the cornea of oxygen, then you get hypoxia and neovasc. So you have to be really, really quite careful with how you fit them.
See, if you have a scar in the cornea, you usually don't get the RGP to settle well or center well.
Correct.
So how much of a lag, and it's sometimes there's a lower lag. So how much of a lag would you say allow for a scar? You know, definitely that you are not going to get it centered. And now because in India at least the scleral lenses are more widely available, I think that instead of going through that, the entire transition of an RGP and intolerance as a primary
Totally.
thing.
Yeah, so I judge it based on the topography, but a primary use is now scleral lenses. You won't go through the whole process of trying to fit an RGP because you're entirely right. If it doesn't center properly, you're going to end up making the scarring worse. So scleral lenses are first line treatment when the corneal irregularity is too high.
So, Professor Chan, the photokeratitis that you have described, we have seen it in India also, and that happens. Some of the studies that they've done in India, it was like based on, I think, probably if you stare too hard at these, that's right staring at us. So they said that this usually occurs when the casing is damaged. So in your situation, it was the etiology of that exposure was different. Probably it was because the light sources itself were this, because these are not UV sources, but because the casing around it is damaged, then they get that
Yes, and in literature, we often see that when the casings are, I echo your view, when the casings are not appropriately maintained is when photokeratitis happen. But for the mass keratitis documented recently, and looking back at the outbreak around 10, 15 years ago, it was related to an improper installation to begin with. So the UV lights are available generally and publicly, but usually it's installed for disinfection purpose instead of a decorative purpose. So perhaps it's a problem in Hong Kong that these are readily available but lacks monitoring. That's why there's improper installation to begin with.
So on a lighter note, whenever we had this couple of these outbreaks out here, and the headlines would read, red eye because of Chinese lights. Because most of these lights, we don't, probably now they're manufactured in India, but earlier these would all be imported. So the newspaper headlines would be. But fortunately, at least in the reports out here, they have not led to permanent damage. So what about the Hong Kong outbreaks? Have you seen a lot of permanent damage there?
I think the presentation and the clinical course echoes that of a solar skin burn. For example, when you went to a beach and you did a lot of activities and a few hours later you get your sunburn, but eventually you'll get out of it. So I find that similar to photokeratitis. As illustrated in our cases, they presented a few hours later. The clinical course are very quick. Usually patients only come for 1 to 2 visits and they are done and they have been completely recovered. And one thing I would like to add is that it's very interesting to find out that all of the patients who presented are not those, they are either not on any prosthesis or either they are on contact lenses. So I suspect that if the patients, those are wearing glasses, they have already some UV filtering effects. So none of them presents to our department. So this could be something interesting and worth further investigating for.
Just a last note on that. Sometimes, if the eye care setting is different, like probably in Hong Kong, there's 1 or 2 where people go. Sometimes they may present to separate physicians, and then it can be a differential for actually an acute conjunctivitis outbreak from viral or something. So probably a history taking that this should also be probably included in the differentials of acute red eye, and especially when there's a outbreak kind of a situation.
Thank you very much. It falls to me to wrap up this session on managing corneal, conjunctival and anterior segment trauma. We had about 60 or 70 people, but I see that we've diminished to about half of that as people have gone for lunch. So thank you for those who are leaving for lunch. Thank you for those who stayed to the end. I must thank my co-chairs, the speakers, which really have presented a diverse and excellent standard of presentation, which kept us all very interested. And the audience for participating. Enjoy the rest of the meeting. Thank you very much. That is brilliant work. I shall get my team to start using the codes. Yeah. Because we see a lot, nothing.